Good morning, everybody. This is Victoria from Michigan Center for Rural Health. Thank you for joining us for our first MIPS education webinar for our MIPS series, the first of 12. These are going to be recorded and then will be posted on our website. If you have computer speakers, you can listen to the audio through them. Otherwise, you can dial in through the phone line. Our first webinar is called From Volume to Value. And with that, I'll hand it over to Brian and Lisa.
Thanks, Victoria. This is Brian Bauer and Lisa Lucida with Hall Render. The Michigan Center for Rural Health has reached out to us to put together a series of presentations specifically on MIPS. We'll talk a little bit about MACRA and QPP, the larger umbrella for MIPS, a little bit today. But the real focus is going to be how to help you successfully report and navigate MIPS so you don't get a negative adjustment. Excuse me. We'll have a series of 12 webinars. There's going to be one a year, or one a month, sorry. One a year would be a long time. One a month. And we'll cover each of the little segments more in depth. Today is going to be more of an overview. We have specifically some objectives today. We want to make sure that we get a high level understanding of CMS, MACRA, QPP. The interesting thing I think about MACRA is it's introduced a whole new set of acronyms that everybody has to get familiar with. The QPP, QPs, partial QPs, MACRA, all of those things that we need to make sure that we get a comprehensive understanding. We'll do an overview of MIPS today. Again, today it'll be more of a high level because each of the following sessions is going to get in depth and into the weeds and the details in each of the various sections going forward. We'll talk some about the reporting deadlines and performance thresholds, and we'll also have a brief summary of the advanced APMs. But I want to stress again that the focus for these presentations is going to be practical and bottom line oriented. What we really want to do is help each of you make improvements and changes in your practice, give you guidance and strategies for what you need to do so you don't get a negative adjustment. We want to make sure you'll see a kind of a reoccurring theme over the next months, 15 and beyond, 15 points and beyond. For the 2018 reporting year and the 2020 reimbursement year, if you have at least 15 points, if your score is at least 15 points, your performance score is at least 15, you will avoid a negative adjustment in your reimbursement. And so that's our goal. Obviously, we'll shoot for much higher than that so you get a positive adjustment, because in 2020, based on the 2018 reporting, it's either a positive up to a positive adjustment of 5% or a negative adjustment of 5%. So although we want to make sure that you avoid the negative adjustment, we're not going to just be satisfied with just a non-adjustment or neutral. We do want you to get into a positive adjustment, get some additional increase in your reimbursement, but that's going to be a reoccurring theme for us. So the agenda for today, introduction, MIPS history, and reporting for 17 and 18. So MIPS is really a child or a part of MACRA. The Medicare Access and CHIP Reauthorization Act. Again, it always amazes me with CMS. They even have an acronym within the acronym because, of course, CHIP is an acronym. So, but basically what MACRA did, as far as we're concerned, the focus today on MIPS, is it got away from the old reimbursement adjustment. The sustainable growth rate that was implemented seems like forever ago now, but the sustainable growth rate really tied adjustments to physician reimbursement to the GDP. And if the GDP went up, then the reimbursement adjustment went up. The problem is, for a long time, the GDP wasn't doing what it should, and so except for Congress stepping in with legislative adjustments, you would have actually had negative adjustments to the physician compensation. Instead of getting increases in the reimbursement in the physician fee schedule under Medicare, it would have actually gone negative. Actually, by the time MACRA came into place, if the SGR had actually been implemented that year, it would have been, I think, a negative 23% adjustment in physician compensation. So obviously something was needed. So we got MACRA, and as a part of that is MIPS. The concept, of course, is that it's supposed to tie volume, or supposed to move away from pure volume and tie value to compensation increases. And so it laid there. Actually, MACRA laid on Congress's desk for about a year before they actually passed it, adopted it, 15. Now we actually rolled out, and last year was the first year for reporting. 2017 was the reporting, and that will speak to or determine what the physician compensation adjustment is for each of the physicians that are required to participate in MIPS. It will dictate their adjustments and reimbursement for next year. So 17's passed. There's not a lot we can do about that. We'll talk a little bit about it, but there's not a lot we can do about it at this point. The deadline for reporting was actually the end of March, just about a month ago. So what the reimbursement will be, what your reimbursement adjustments in 19 will be, are already determined. So I think over the course of our conversations, there'll be some discussion of that, and I don't want to minimize that, but I don't want to lose focus on the fact that we really need to focus on reporting at 18 so that we have a positive adjustment in 19. Last year, CMS recognized the fact that the industry wasn't ready for MIPS. Nobody was set up and even really aware of it. Everybody was thinking, I think, that 2019 was when the adjustment was going to come into place, and so they really weren't paying attention to the fact that 2017 was going to generate their score for the 2019 adjustment. And so CMS basically gave 4 different ways to report, or 4 different ways to engage. And if you reached a minimum of, basically if you did any reporting at all in 17, you avoided a negative adjustment. Going forward, however, it's a little bit different, and I know Lisa's going to talk more about the MedPAC recommendations and such. So I don't want to get too off into that at this point. So the quality payment program, some of this I've touched on already a little bit, but I think it's important to take a look at some of the language, the way CMS talks. QPP is an alternative to the traditional fee-for-service models. In some ways, that's not really true. I mean, that's CMS speak and think. Fee-for-service isn't going away, but the adjustment in the fee schedule is going to be governed by the QPP, the Quality Payment Program, of which Advanced Alternative Payment Models is one track and MIPS is the other track. It does take a comprehensive approach to payment with a focus on patient-centered healthcare. I think that's CMS's view of it. Lisa's going to talk in a minute about MedPAC's perspective on it. But I think it's good to understand that this is CMS's intent and thinking. Whether it plays out completely, I think that remains to be seen. I think we'll probably see some adjustments going forward, just because some of the comments that MedPAC has made and some of the just experience, I think, will probably drive some changes as well. And it's intended to recognize and encourage improvements in clinical practice. So what's the big deal about QPP? Well, depending on the size and nature of your practice, where you are with your practice, it could involve a large amount of investment. to actually get up and running and prepared for MIPS. And that's part of the reason CMS did what they did last year and really scaled back on the requirements. Going forward, 19, 20, 21, 22, we're going to have payment adjustments based on your MIPS score. And so obviously it's a big deal there. The bottom line is the bottom line. QPP and the focus for our discussions is MIPS is going to make a difference to your bottom line. Doing what you need to do under the program in order to get hit the minimum threshold to avoid a negative adjustment is something that's got to be a focus. 4% is the adjustment in 19, 5, 7, 9% is what it goes up to. So it's going to make a difference. What clinicians are affected by the QPP? Physicians, PAs, nurse practitioners. I think, the thing to kind of think about is that MIPS, the QPP, but again, the focus on MIPS today, really is an adjustment to the physician fee schedule. So if you're a provider that's compensated by Medicare under the physician fee schedule, you're going to be impacted by MIPS and the QPP and that either positive or negative adjustment. So I've been talking about QPP, and there's two tracks. One is the merit-based incentive payment system, which is MIPS. Sorry, this is another one of those kind of wonky things that just always gets my attention. Merit-based incentive payment system, technically, if it was just an acronym, should be MIPS, but they even define their own acronym. And that's where we're going to place our focus. There is, under the QPP, also the advanced alternative payment models, which gets you out of the MIPS reporting, but there's a fairly high threshold there to be involved in that. You not only have to be involved in an alternative payment model, but you have to be in an advanced alternative payment model. So a little bit of history. We talked about some of the history, but it's important to understand that MIPS really sunsets three of what's been kind of the initial CMS value-based payment models for physicians over the last 5+ years. PQRS, value-based payment modifier, and the Medicare EHR incentive program, they're all sunsetting and getting rolled into MIPS. And they each kind of fall within one of the qualities or one of the categories under MIPS. But it's important to understand these programs are going away altogether, and we're getting a brand new program that brings them all in. So it moves, again, from Medicare's perspective, MIPS moves Medicare Part B clinicians to a performance-based payment. You earn a payment adjustment based on evidence-based and practice-specific quality data. And the goal is to show that you've provided high-quality, efficient care supported by technology. And we'll see the various categories here in a minute, but each of those has their own CMS focus of the direction that CMS wants you to go. So, and then there is, I do think that CMS did try to build some flexibility into the activities, the practice improvement activities, the quality metrics or measures that you can choose from. There's a great variety there. So the concept was to build in some flexibility for each of the practices. So who participates in MIPS? Well, we talked about that it's basically anybody covered by the physician fee schedule. There is a couple of carve-outs. There is the low volume participant. You'll see there the information on 2018 for this year's reporting year. The threshold's actually gone up. So if the Medicare Part B clinician does not bill more than $90,000 a year and provide service to more than 200 Medicare patients, then they're a low volume provider, and they are not subject to MIPS and the MIPS reporting. You're probably also aware that RHCs that get and FQHCs that get paid under an all-inclusive rate are also excluded. I think it is important to understand that after the first 2 years, eligibility may expand to other categories of eligible clinicians, like physical therapists. Actually, the statute, NACRA, actually requires that. I think CMS is understanding that they may not be able to run that out or advance that as quickly as they would like, but that is coming. And so then we have these 4 categories. And there's points for each category. They're added together to give you your final MIPS score. The MIPS score is compared then to what's referred to as the MIPS performance threshold to determine if you receive a positive, negative, or neutral adjustment. And we'll get in the following months and the following webinar presentations. We're going to do a deeper dive into each of these categories so you'll understand them and what you need to do to maximize the points for your practice and your score. But one is quality. One is the category of quality. Cost, there actually isn't a reporting mechanism. The cost data is collected by CMS purely from the claims data. The improvement, clinical practice improvement activities, or shortened here to improvement activities, are things where the CMS wants to see the practices do more to engage with patients, and then advancing care information is the focus on EHR, renamed and retooled, I should say, but the focus on making sure that the practices are moving to an electronic EHR, an electronic basis, to be able to share that information more readily and quickly in order to better manage and coordinate care with patients. And so I've mentioned a couple times the upside, downside risk under MIPS. So depending on your score, and the blue bar or the blue arrow there in the center moving from left to right is the performance threshold. That's the minimum score that CMS determines each year, that if you're above it, if you're at that score, it's a neutral adjustment, neither up or down. You just keep getting what you received last year as far as your reimbursement under the fee schedule. If you're above it for 2000, if your score was above the performance threshold, which was 3 points for 2017, then 2019 you'll have a plus, could be a plus of 4%. Going forward, obviously, based on the reporting year this year, 2018, your potential plus or negative adjustment is 5% in 2020, and then moving forward, you can see there. So I think at this point, I'm going to turn it over to Lisa and let her kind of walk you through, when does the whole MIPS and how does the MIPS program work and roll out for you?
Thank you so much, Brian. So I'm going to walk you through the time frame and some key reporting deadlines and dates that you should be aware of in terms of reporting under the MIPS program. So the 2017 reporting year was the initial year that MIPS began. That period opened up on January 1, 2017 and closed on December 31st, 2017. During that 2017 reporting year, you were expected to record quality data and demonstrate how you use technology to support your practice. On March 31st, 2018, so just about a month ago, you were expected to submit your 2017 performance data. CMS will take a look at that data, and based on your scores, you will either receive a neutral, negative, or positive adjustment to your Medicare Part B reimbursement starting on January 1, 2019 for whatever you reported and did in 2017. So again, you were expected to submit that 2017 data by March 31st, and then those payment adjustments will be made effective January 1, 2019 to your fee schedule payments. For 2018 reporting year, that will shift a little bit. So the deadline for the 2018 reporting year will be March 31st, 2019. And then the payment adjustments for your 2018 reporting period will be effective on January 1, 2020. So there have been some important changes that have occurred between the 2017 reporting year and the 2018 reporting year that you all really need to be aware of. The first and foremost, most significant change was the increase in the performance threshold. So the bare minimum was to achieve 3 points as the minimum threshold to achieve a neutral payment adjustment, meaning you don't get hit with a negative adjustment for 2017. That amount increased to 15 points for 2018 reporting. So now you're expected to achieve at least 15 points to avoid any sort of negative payment adjustment on a go-forward basis. What didn't change was the exceptional performer threshold, so that remained the same at 70 points. Under this category, you may be eligible, well, you will be eligible to receive an additional performance bonus if you achieve 70 points or greater, in addition to the positive payment adjustment. Another change that occurred was the payment adjustment was set at positive or negative 4% for 2017, and that increased a percentage point to positive or negative 5% for 2018. So you'll see that change in your reimbursement in the 2018 reporting period. So this slide kind of details in greater detail the changes in the scoring that have occurred between 2017 and 2019. The most significant being that minimum 3-point to now 15-point threshold to avoid any negative payment adjustment. So now you're expected for 2018 to achieve at least 15 points. If you didn't report anything at all, you will receive a score of 0 points for your 2017 reporting period, which will ultimately mean you'll receive a negative payment adjustment of 4% to your Medicare Part B payments. It's a little bit different for 2018. You'll see at the bottom of the second column here that if you don't report at all for 2018, or if you score between 0 and 3.75 points, you will receive that negative 5% payment adjustment. And then if you look up to the next column, you'll see if you score points between 3.76 to 14.99, just under that 15-point threshold, you will receive a negative payment adjustment, but it may be an amount between that negative 5% and 0%. So very important on a go-forward basis. And Brian and I, as he's already discussed throughout this presentation, our goal for the next 11 webinars is to really make sure that you understand how you can get to at least 15 points with the ultimate goal of getting beyond that minimum threshold, so we can get you in that positive payment adjustment category for your 2020 Medicare Part B payments. So with all this being said, and Brian's mentioned this too, there's been a lot of criticism of the MIPS program from industry stakeholders. Just a month ago, in fact, in March, the Medicare Payment Advisory Commission, otherwise known as MedPAC, released its biannual report to Congress and made a couple recommendations. And the biggest recommendation was that Congress eliminate MIPS altogether. And they included several reasons why they made this recommendation. The first being that MedPAC believes the system is inequitable. Clinicians are evaluated and compared on dissimilar measures, and many clinicians aren't evaluated at all because they lack a sufficient number of cases for statistically reliable scores. MedPAC also believes, and we've talked about this too, that it's based on predecessor Medicare programs that have generally failed at improving patient outcomes and care processes. Additionally, MedPAC believes that MIPS imposes significant reporting burden on clinicians, which MedPAC believes outweighs the patient benefit. So the ultimate goal that CMS is trying to achieve is to shift the focus away from fee-for-service reimbursement based on volume and focus more on quality outcomes. But that comes along with, as you know, pouring in additional resources to your practice, making sure you have advanced technology to meet these requirements, and imposes quite a burden on you as a clinician in your practice in making sure you're able to achieve these outcomes. Finally, MedPAC also believes that it fears that MIPS will encourage you as a clinician to focus on selecting measures which you'll expect to do well in, and that kind of takes away or undercuts the shift in focus on improving patient care. We'll go ahead and just briefly conclude the presentation by talking about that second track to the quality payment program, which are advanced alternative payment models. This payment model is a subset of advanced payment models. It's a payment approach that provides added incentives to you as a clinician and provide high quality and cost efficient care. It typically applies to a specific clinical condition, care episode, or population of patients. Eligible clinicians and practices are able to earn greater rewards for taking on some risk associated with your patient outcomes. And you may be eligible to receive a 5% lump sum bonus if you participate in an advanced APM. So this slide includes a list for the 2018 CMS approved advanced APM models. You may or may not be participating in some of these already, but I think it's important for you to be aware of what the 2018 approved models are for an advanced APM. Some of which are under the Medicare Shared Savings Program, Tracks 2, Tracks 3 in the Medicare ACO Track 1 Plus model. And under those models, you do take on a little bit more risk than the traditional ACO models. So what happens when you're an advanced APM? Well, once you're an advanced APM, you'll earn the 5% incentive payment for 2020 for your participation in an advanced APM in 2018 if either you receive 25% of your Medicare Part B payments through an advanced APM, or if you see 20% of your Medicare patients through an advanced APM. So you need to meet either of those thresholds. It's important to note that if you're participating in an advanced APM, you are exempt from MIPS reporting. However, you will not be exempt from MIPS reporting if you participate in a MIPS APM. If you're in a MIPS APM, you may be scored using a special APM scoring standard, and this standard will help eliminate the need for MIPS clinicians to duplicate submission of quality and improvement activity performance category data and will allow you to focus on the goals of the APM. So it eliminates duplicate reporting. So at the end of the day, what does this all mean for you? Essentially, this comes down to the focus on quality and good patient outcomes is not just a moral obligation anymore. You as a provider will now be forced into improving and maintaining quality for business purposes, not just for patient care. So at the end of the day, quality will impact your bottom line, and it's really important that you're able to focus on achieving good patient quality outcomes so that you're going to avoid negative payment adjustments on a go-forward basis.
Thanks, Lisa. Here's a list of the topics for the next 11 webinars. And as you'll see, what we're really trying to do is drill down. We've kind of touched on the QPP today, both MIPS and the Advanced Alternative Payment Models, or APMs. But we're really turning our focus to a more in-depth understanding of MIPS starting in May, and then running through the following months. We're going to take each of the categories and just spend an entire session or webinar on each of the categories. And then as we get further along in the year, we're going to even get a little deeper and focus on the specific reporting for each of those categories, so that by the end of the year, you should feel comfortable in understanding the category, quality, advancing care, information, improvement activities. Not only understand the categories, what you need to do, but also what to report, how to report it, so that you maximize your potential score. And then we also do touch on some virtual group arrangements and virtual group agreements. As we'll talk more about next time, you have the ability to report these scores either individually or as a part of a group. And for those of you that are in smaller solo practices, you actually have the ability to knit your solo or small practice together with other solo and small practices and report as a group. And there's some advantages and disadvantages to that. And so we'll talk about that as well. So that's our overview. And then finally in March of next year, because of course, in March of next year, the end will be when your reporting for 2018 has to be in by, and then we're starting and looking forward to the 2019 reporting year and what you're going to need for that and going forward. So with that, Victoria, I don't know if there's any questions, either by text, email, or on the line. If there are, happy to take them. If not, we'll talk to you all next month.
So it doesn't look like we have any questions so far, but if anything pops up, please feel free to email Brian or Lisa, or you can feel free to email me directly, and I will pass your questions along. Thank you everybody for joining us, and have a great day.